Thank you very much to the organizing committee for giving me the opportunity to present this research this morning. This research was funded by multiple sources. There is one for-profit company who paid for some of our statistical analysts, Varian Medical Systems. I'm a salaried employee by MD Anderson and have no other sources of income. I am a radiation oncologist, however, so you can decide if that's a conflict or not. There are about 140,000 women diagnosed annually with early breast cancer in the United States. And for these women, most are going to be eligible for at least one or two or more of these local therapy options, including lumpectomy plus whole breast irradiation, lumpectomy plus brachytherapy, lumpectomy alone, mastectomy alone, or mastectomy plus reconstruction. When patients receive local therapy that's concordant with guidelines, our feeling is that their survival is excellent and essentially equivalent regardless of the local therapy chosen. However, these local therapies differ significantly in the extent of surgery and radiation that is delivered. As another point of background, mastectomy rates in the United States have been increasing for early breast cancer, and this is a study that was published earlier this year in JAMA Surgery using data from the National Cancer Database, and they reported that nearly 40% of women with early breast cancer in the United States were treated with mastectomy, and that the proportion of women treated with mastectomy increased substantially between 2005 and 2011. And then of these women who underwent mastectomy, approximately 40% underwent post-mastectomy breast reconstruction. And the use of post-mastectomy breast reconstruction in the United States also increased significantly over this time frame. There are multiple reasons why a woman may choose to have a mastectomy over a lumpectomy. There are certainly medical indications such as multifocality or multicentricity or the presence of a heritable genetic syndrome, but recent literature also indicates that patient fears and misperceptions often drive the choice for mastectomy. Notably absent is the concept of value when making determinations about the best local therapy for women with early breast cancer. In light of this background, our primary objective was to improve the understanding of the relative value of local treatment options for early breast cancer by comparing their complication burden, total cost, complication-related cost, and non-complication cost. To do this, we assembled two unique non-overlapping cohorts. We used a large commercially available database called the MarketScan Commercial Claims and Encounters Database. This captures younger patients under the age of 65 with private insurance at the time of diagnosis. And this is simply an amalgamation of claims. There's no cancer information directly in this database. In addition, we use the SEER Medicare data to study older patients aged 66 and older at the time of diagnosis. And this is a population-based data source which links Medicare claims to tumor registry data abstracted by registrars whose data ultimately flows to the National Cancer Institute. And this represents approximately 26% of the United States population. One of our primary outcomes was the presence of any complication. And to define these complications, we assembled this set of ICD-9 and CPT codes to reflect the common complications that one might see after local therapy for early breast cancer. These outcomes included wound complication, infection, hematoma seroma, breast pain, fat necrosis, radiation pneumonitis, rib fracture, graft or implant complications, implant removal, and other postoperative complications. To assess cost, we looked at all claims that occurred between diagnosis and 24 months after diagnosis to assess total cost, and costs were adjusted for medical inflation and are reported in 2014 dollars. We also identified complication-related cost, which we defined as the sum of all costs that occurred on days when a complication was noted in the insurance claims. We also define non-complication cost as the difference between total cost and complication cost. And you could think of non-complication cost as essentially reflecting the baseline cost of these different treatments if no complications were to occur. So what did we find? In the MarketScan cohort, which was about 44,000 patients, the median age was 53, and the most common treatment was lumpectomy plus whole breast irradiation with 38% of patients. Mastectomy alone and mastectomy plus reconstruction were the next most common, each representing approximately 1/4 of treated patients. In the SEER Medicare cohort, which had approximately 60,000 patients, the most common treatment was also lumpectomy plus whole breast irradiation, nearly 50% of patients, with the next most common treatment being mastectomy alone, and of note, relatively few patients in the older SEER Medicare cohort were treated with mastectomy plus reconstruction. When evaluating the outcome of any complication, the treatment group associated with the highest risk of complication was mastectomy plus reconstruction at 56%, whereas the treatment associated with the lowest risk of complication was mastectomy alone at 25%. In the SEER Medicare cohort, similarly, mastectomy plus reconstruction was associated with the highest risk of any complication. In this cohort, all complication risks were somewhat higher, and mastectomy plus reconstruction, the risk was 69%. In contrast, the treatment associated with the lowest risk of any complication was lumpectomy alone. We created logistic regression models for the outcome of any complication, adjusting for age, race, comorbidity, chemotherapy receipt, axillary surgery, and nodal positivity. These are two separate models in two separate cohorts, and notably we found very similar findings. So relative to lumpectomy plus whole breast irradiation, treatment with mastectomy plus reconstruction was associated with nearly twofold increased risk in the outcome of any complication. Of note, lumpectomy plus brachytherapy was also associated with a modest increased risk in any complication, ranging from 36 to 46% increase in risk. When we evaluated total cost, remember this is any cost occurring within 2 years of diagnosis. In the market scan cohort, we found that mastectomy plus reconstruction was the most expensive treatment, and mastectomy alone was the least expensive treatment. And relative to the most common treatment, lumpectomy plus whole breast irradiation, mastectomy plus reconstruction was $23,000 more expensive per patient. In the SEER Medicare cohort, the most expensive treatment was lumpectomy plus brachytherapy, and the least expensive treatment was lumpectomy alone. And again, looking at the difference between lumpectomy plus whole breast and mastectomy plus reconstruction, mastectomy plus reconstruction was associated with approximately a $2,000 increase in cost per patient. When evaluating simply complication costs, to me one of the most surprising findings of this study was that the average patient treated with mastectomy and reconstruction who has private insurance results in a complication cost of $10,000 per patient. And this is approximately $9,000 higher than the cost of complications with lumpectomy plus whole breast irradiation. Similarly, in the SEER Medicare cohort, mastectomy plus reconstruction was also an outlier, with approximately $2,500 increased cost per patient compared to lumpectomy plus whole breast irradiation. When evaluating non-complication costs, which could be thought of as treatment costs in the absence of complications, again, mastectomy plus reconstruction was the most expensive treatment in the market scan cohort, and approximately $15,000 more expensive than lumpectomy plus whole breast irradiation. In contrast, in the SEER Medicare cohort, mastectomy plus reconstruction was slightly less expensive than lumpectomy plus whole breast irradiation, about $700 in the black, as I've shown here. So this indicates that mastectomy plus reconstruction is not terribly more expensive if you can avoid complications in older patients who are Medicare beneficiaries. This study has some important limitations. First of all, not all patients included in these cohorts would have been eligible for all the different treatments, so our findings represent what the average patient treated with these treatments can expect in the community setting. And also, I would be the first to acknowledge that assessing complications via claims codes is imperfect and doesn't necessarily reflect the severity of these complications. There's a very important caveat which I think needs to be clear when interpreting these findings, and that is that these findings are most relevant to patients and payers when contemplating initial management, and both lumpectomy and mastectomy are viable treatment options for a patient. However, if a mastectomy has been performed, reconstruction is generally considered to be a high-value intervention, and it would be inappropriate to conclude otherwise from the data that we have presented. So in conclusion, there's a twofold increase in complications with mastectomy and reconstruction compared to lumpectomy plus whole breast irradiation, resulting in excess cost. The complication burden is modestly elevated with brachytherapy, but cost of complications is minimally higher than lumpectomy plus whole breast. And that complication burden and total cost are lowest with mastectomy alone for younger women and lumpectomy alone for older women. For women who wish to preserve a breast mound, lumpectomy plus whole breast irradiation appears to be a high-value treatment for younger women, and either lumpectomy alone or lumpectomy plus whole breast appear to be high-value treatments for older women. And I would add that the value of lumpectomy plus whole breast irradiation could be further improved if radiation oncologists adopt shorter, more cost-effective schedules for delivering whole breast irradiation. Thank you.
Thank you very much. Dr. Smith, excellent presentation in line with the previous one, actually. So clearly this has implications, may have implications that allude to the choice of procedure that women make, but what do you think about this does to the landscape of local regional therapy? What are your thoughts on that?
Yeah, so you know, at MD Anderson every Tuesday afternoon, you can find me in a clinic seeing people with brand new diagnosed breast cancer. They haven't had any therapy yet, and I see them with a breast surgeon and a breast medical oncologist. And I was interested in doing this study about 2.5 years ago when we started that clinic, and we would offer patients all these different options. And we didn't have a really good framework for understanding what were the trade-offs for patients, particularly if they would opt for mastectomy and reconstruction as opposed to lumpectomy and whole breast irradiation. So I think these findings are actually really helpful for framing what are some of the early trade-offs within the first 2 years for patients who opt for one treatment versus the other. And I think they can be integrated into giving patients a fuller picture of what to expect with the different treatment options. You know, we're doing a study now to look at the number of different days patients have to come in within the first 2 years with either mastectomy plus reconstruction or lumpectomy plus whole breast irradiation. And it is actually clear that if you have reconstruction, although it's a little more burden, you get to stay home a lot more than if you have to come in for, say, 5 or 6 weeks of radiation. So we continue to try to flesh out some of the pros and cons of these different choices. But our main goal is to provide more information that can be helpful to women to make the most informed decision possible.
Thank you.